Hello.
Yeah, Dr. Kaul, we can see you now.
Hello, Upendra.
Yes,
Morning.
good. Good morning. Good morning. Well, I'm here with my colleague Dr. Praveer Aggarwal and our colleagues Dr. Ajay and Dr. Ranjan. And we have a case which has an interesting history and is a case meant for conventions. His first procedure was done in August of 2016 at TCT India.
Upendra,
And
the audio
that
is not
time it was
good.
Dr. Praveer Aggarwal. Can you improve the audio?
We can see you
Is it
very
better
well,
now?
but the audio transmission is not optimal. Difficult to hear you.
Okay. Is it any better now?
Sounds better.
Yeah, you can present the case.
Okay. Okay. This is a 73-year-old gentleman who has a interesting history of having had one procedure in the past, and that procedure was done in August 2016. And this was done when TCT India meeting was there, and I was moderating the case at the venue, and Dr. Praveer Aggarwal, who is with me on my right, he was the operator. So I think let the case be presented by Dr. Praveer Aggarwal first.
Good morning. The gentleman
And
who
we
was
lose the
72
audio
years
again.
old
It's
is
too
a
soft.
type 2 diabetic,
It's better.
hypertensive,
Yeah.
presented in August 2016 with worsening dyspnea for last 1 year. His ECG was unremarkable. His echo was normal. Can we have the next slide, please? See the angiogram. Considering the clinical history, the RCA has got bad calcium all through the proximal mid segment and a tight stenosis. Next, please. And that's the left system. Circumflex is totally occluded, a small vessel, well carotidized. Next, please. Next, please.
Can you show the next slide?
Next slide, please.
I think you go ahead and what you
See,
do.
the LED showed the moderate lesion at that time. Considering the physical state of patient, we decided that look, RCA looks to be the culprit of the main symptoms. But to prove our point, we did a thallium scan on him at that time. And thallium showed inferolateral ischemia and the LED was fine.
You mean the septal area was fine?
So at that time we decided that look, we should just treat his RCA and leave him alone for the left system. Can we have the angioplasty slide for the last procedure? I'm sorry for the waiting because there's some scuffle in the video. Yeah, can we have a larger screen on? This is on a larger screen, yes. Initially, it was difficult wiring, even a rota wire would not go. And even I tried a BMW wire on that, no fine cross would go, so this was difficult wiring. So I started burying, even the wire was not too distal in the vessel. After some wiring, there was some space for the wire to go, and the wire went distally. And this was done on root, and this was done on a rotation of the burring. When the burr was rotating, I pushed the wire down. After drilling for about close to about 20 minutes, I could just drill about 2/3 of the RCA, but the distal part was not crossing. There were a lot of suggestions at that time from the auditorium that take a different guide, do things, but nothing was happening, and I did not change my strategy yet. And at the end of it, it was a second new burr that helped me to cut the distal most lesion. Now you can see on the screen, the distal most portion is now, the burr is going through. Then the job was easy. Next, please. Next, please. Next, please. Yeah, this was the final result at that time, and he got relief in symptoms for next 6 months. Now he again presented to us with worsening dyspnea for last about 1 month, and an episode of unstable angina about a week prior to admission. So we did repeat an angiogram. Can we have the last angiogram?
I think let's show today's one.
Uh,
I think at this stage, let us show today the pictures of today.
as the time is running short,
Yeah. You see, as you can see, the last angio shot after the procedure showed that the right coronary artery distally, PDA and PLV, there is a lesion, but which was angiographically not significant. Not significant. So with that in mind, we took him back today and did an angiogram, and let's see today's shots. So this is today's shot. We straight away started with a guiding catheter, and as you can see that the stent is widely patent, some mild stenosis in the proximally, but distally there is a lesion which is extending into a large PLV. So at this stage, we thought that we should do an FFR, and let us see the FFR. So the FFR very clearly showed that this is a significant lesion. The FFR was 0.74. Okay. Now let us go to the left side. This is the shot from again taking with the guiding catheter, and here you can see that there is a stenosis in the mid LAD which is quite significant angiographically. Once again, I won't say that it is more than 90%, but this is something between 70 to 80%, and the vessel is densely calcified proximally as well as at the site of the lesion. So once again, we thought, let us do an FFR, and let us see the FFR. And this is the FFR wire, and the FFR again shows that this is a significant lesion. This is a significant lesion with an FFR of 0.73. Then we decided to do a pullback to see what is the extent of the lesion. So when we pull back, we see that the major pressure difference of about 12 to 13 millimeters is between the septal and the diagonal. the second diagonal, and so this is the region which which needs treatment, and in view of the severe calcification and the past experience of our right coronary artery angioplasty, which was very complex, so we thought we need to do an angioplasty. And so what are the views of the panel? What should be done? Whether we should do this vessel, the right vessel, or what should be the sequence? Whether we should go with a balloon, whether we should go with a rotablator or some other device.
Upendra, as far as the LAD is concerned, I think it's an extensive disease, starting right from the ostium and
Yes.
going to the mid segment. And there is a significant
Yes.
of calcium also there,
Yes,
and a good size
yes,
diagonal also. I think with the extensive calcification,
Yes.
I think rota would be the ideal thing first to do in this case.
Yeah, no, I also
Yeah,
looking
that's what
at
we
to
thought,
say something
and-
in this room
yes.
about that a lima to this LED, which has a perfect landing zone, is something which is going to be patent for a long time potentially.
yes.
It's too late.
Yeah,
think
now
that,
that's too late
yeah,
for today.
In this kind of quite long, diffuse, calcified lesion, starting
Yes.
from the ostium of the LAD to the distality of the mid segment of the LAD.
The physical
I
condition
would
at the
prefer to use,
like initially also was not too good
rotational
for a bypass.
with a 1.25 or 1.5 millimeter burr, and followed by a balloon using a non-compliant
Hare
balloon,
Krishna, please.
2.5 or
So
2.75,
that's
and
what.
then following by a
Yes.
metallic stent.
Yeah, that's what we thought about, and this is the rotor wire which is in position.
Hare Krishna, please.
What?
Definitely, if you're going to treat this as PCI, I think balloons won't not be sufficient, so you need to rota. That will be better debulking and
Yeah.
fragmentation of the calcium.
So here we are advancing the bar, which we have selected a 1.5 millimeter bar.
1.5.
We have gone with the
It's
yes
not- it's not a
1.5
very
bar,
large
and
vessel.
we've gone with a 7.
When you look at you are in the 6
Yeah.
French guiding catheter.
No, this is a 7 French, 7
It's a
French
7
guiding
French,
catheter. We
okay.
usually use a 7 French guiding
But
catheter.
just to estimate the
7
size
French.
of the vessel. So it's a 7 French, the
Yes.
vessel will be a little bit larger.
Yeah, the vessel looks not more than 2.5. So here we are.
Go to cranial, please.
Yeah.
Using a 1.5 millimeter burr,
Can
we
we
are in the
go? Cranial?
really the safety
Cranial, please.
zone of the diameter of the burr. In other words, the ratio,
That's right.
burr size, vessel size, it's no more than 50%.
So the guide wire tip,
So this is at the proximal. Yeah,
That doesn't matter.
yeah.
Can we just come to Hare Krishna, please?
Ariocaudal. Yes.
Just come inside.
Take a shot.
No, sir. The bar is outside right now.
Okay.
Have you just close
What will be the speed, the rotational speed?
I think it
about
will be more than 175.
Okay.
Plus, अभी अभी delay करना सभी को. Can
Okay.
we just come back?
Let's
Cranial?
go back to the cranial.
Let me take the shot for the landing zone.
Okay.
Just take shot, ladies.
So here we start just before the diagonal.
Just a message should come in.
Okay. Can you show the revolution rate? And this is the typical pecking motion which we're doing, and and that is the point where the bar is not crossing, and you can see fluoroscopically also very dense calcium there.
The speed is 175.
There is no drop, we're just keeping it there. 175, 174, 175. We're not allowing a drop. Just at the site, not giving way. Reminding us of the right coronary artery procedure.
It's okay.
This is the hard point. Yeah, 168, 169. Just giving a breathing space, some time to breathe.
Can we see an angio just to see
Fluoro.
how is the result?
Yeah. Do you think we should downsize? Should we go with a 1.25 bar?
Yeah, I think so.
I think that the distality
Because,
of the LED is not too bad. There is a good diagonal. I think you could do it with a 1.5
Fluoro.
using the picking technique and maybe increasing the speed to 200.
Okay.
Fluoro.
Okay.
200,000
That's what
RPM.
we'll do.
Fluoro.
Okay.
Fluoro.
And do not force, just the picking.
Okay. Yeah. We're just taking it. That's right.
Back.
Just keeping it there. Yes.
Back.
Go up.
Then
180 down.
166, 178,
200.
Patient.
180. We just increase.
Just back and forth.
The patient is stable, the ECG is stable, the pressure is stable. But we're just there,
Yeah.
just with the pecking motion.
It will cross.
Can go
That's
to
a matter of
190.
patience.
Yes, yes. That's
190.
right. Some time to breathe.
Fluoro. Fluoro.
Once again,
ECG is good.
ECG is good. The pressure is absolutely stable. Some T wave inversion coming in the lead 2 and lead 2. Heart rate is stable. We've gone up to 180,000. Again, some still not getting through.
Fluoro. Fluorescent. Fluorescent.
Doing it again. That's really resistant.
It has gone through.
Okay, it has gone through. We feel it has gone through now. So we're giving some breathing space, and then now we'll see it will go.
So fluoro, please.
What you can do is to fix the, the support of your turbine, because when you're advancing, all the system is advancing. I see on the screen. Okay.
Yeah. There's no flow is good.
I'm not cutting anymore. If you can see, this is cutting eccentrically. Right. This cutting is fine. I think. Are you happy with the cutting? Because the cutting has been done.
I think you need to do a more
and the
polishing.
cutting is quite eccentric.
What you can do is to
The polishing,
use
I
one
think,
more
would not
time.
be very, very good solution.
I think you need to go one more time and
One
do
more
the
time?
polish
Let's do.
down.
Be sure that
Okay.
The burr is crossing
Yeah.
the calcifier area easily.
Yes. Yeah. Yeah. See, it crossed.
Right down, right down.
It crossed.
Now, you see, this is what is happening is, yes, right down it will be difficult because you see he's getting some chest discomfort for. Take a second. Take a second.
Try to do a little bit more
Right,
aggressive.
some slow flow is coming in. Yeah,
See, the
I have it.
flow is not the same.
this is
Little
being
slow
drilled.
flow.
So let me just come out.
Some
So
slow
we are
flow.
just deciding right now to floor, sir. Let me take it out. इसको खोल दें, sir.
Yeah.
हाँ, dyno.
So we'll go and do a dynaglide.
Some Dilsen, please.
I think now we should give some
Nitro.
vasodilators. Yeah. Yeah. Okay. The pressures are all right. ECG shows some ECG change. ST elevation, mild ST elevation.
A BMW wire.
So let's cross with the BMW wire. No, we're not taking it out.
Deltiasm. So flow. Because flow is there.
Yeah. Giving some nitro.
Deltiasm.
Yeah,
हाँ,
yeah.
सर, भी ठीक हो
अभी
जाएगा।
देते हैं. Give some dilsem. Let's give some diltiazem. Needle.
Ah, shock your back. With that,
You
no.
see the flow. Flora. Flora, flora, flora. Flora, sir.
Can we see the ancho?
Can we
please?
check the angios? Can we see the angio?
Take it. Yeah. Yeah. So take it, sir.
Yeah. Well, it's slightly
better.
better, but still not perfect.
Can we have a 2.5 non-compliant balloon?
So what we're going to do is to
Higher
go with the
cord, please.
BMW wire.
And,
Aerocordal.
and do not take the other wire out.
Let's go to the cranial view.
Cranial आ जाओ, Yogesh.
Cranial.
When the wire will be
That's
in
a
the
diagonal?
distal
Yeah, it's gone
LED,
to diagonal.
what kind of balloon will you select?
Non-compliant.
We'll use a non-compliant balloon, a 2.5.
5?
Yep.
Which is going into the septal.
You have to come back a bit more. So a bit back more. Bit more back.
Just a minute.
John, I think we don't have so much time. I did see a shock for a moment, so maybe when they are wiring, we can see the results
Okay.
in the room.
Yeah.
Okay.
I don't know if it's possible to do that.
Is it possible to shift on to the other lab while you are working on this? With
Yes, so I
Ashok?
just crossed and
Okay, so what you can do is to move to the other lab.
give the.
We understand that
give the balloon.
you will place the wire in the distal LED, then advance to 5 NC balloon.
Take out
And
the
then
rotor
what
wire.
will be the
Cutting
choice
the
of the stand?
Okay.
I suppose it should be a metallic stand.
So in this case, yes, it will be a metallic stent, and we left the rotor wire there, which will act as a
Body wire.
cutting body wire,
Body wire, yeah, okay.
and we're taking it. Yes, we'll take a 2.5 millimeter balloon, do a dilatation, make sure that the flow is good,
Okay,
and then we're going with a metallic stent. And we're going to use a very thin strut metallic stent from one of the Indian companies called the Merrill. It's called the Evermime. It is 50 microns
okay.
in strut thickness. So this is one of the thinnest stents we have.
So everybody,
Here goes the balloon.
everybody agree that there is in this part, in this kind of calcified vessel, even after rotoblator or
Yeah,
other
this is not
debulking
a-
device,
Yeah, this
there
is
is
not
no
a case.
room, no place for the
This
BDS.
is not a case for. Yes, that's right.
Come back.
Come up a little bit. Okay.
Oh, so for a little. Yeah.
Okay, let's go.
Gently.
Go up.
1, 2, 3,
Gently,
4.
gently. Yeah,
6,
so it has
7, 8,
opened at 6 atmospheres,
10.
7, 8, 9,
We
10,
have 10 more minutes.
11, 12, 13, 14.
12, 13, 14. Okay. Okay.
15.
Come down.
Come back a bit more. Okay, go up.
Go up.
5, 6, 7, 8.
Yes. So it went up at 2,
14,
3 atmospheres,
16,
6, 7, 8, 9.
18.
And let's take a
Deflate,
picture now.
deflate.
I'll just take the balloon out.
Come back. नहीं अभी पहले डायरेक्ट तो करना पूरा. हाँ. Yeah. Come back till the diagonal.
Okay.
Yeah, go up.
Go up.
1, 2, 4, 6, 8, 10, 12, 14, 16, 18.
This is high pressure now.
Deflate.
14, 15.
Come on. Above short everything.
Okay.
यहाँ नहीं करते थे ये लैंडिंग जोन है. Let's avoid that.
Yeah.
And just put the center and then come on.
Hmm.
इसको निकाले बलून निकालने से एक बार शॉट ले लें.
हाँ.
बलून निकालने से बाहर.
balloon निकाले?
हाँ. गाड़ी में ले लें.
Yeah.
Now take a
Okay. So at that stage, I think we should wire the diagonal.
Yeah, we can take this out. And would they prefer a long stand or 2 short stands?
Would you like to prefer a long stent or 2 short stents?
So use 18 atmosphere in proximal, and in the distal part of the lesion, what was the pressure?
8,
Around
8,
18.
9, 8, 9.
18.
8, 9, and then we finally went up to 18 atmospheres.
Yeah. In this particular case, it's so long and calcified. Maybe I will use a
take out
higher
the-
pressure, even in the mid LED, in order to be sure that the stent
Yes.
could
Yes.
cross the lesion.
Expands well, yes.
Can we have another wire, please?
So
Another
You can
BMW.
start with the stent. You will
let's
see.
have
if
another
it's
BMW
crossing
and
or
take
not.
take a picture. The flow is perfect now. So we go with the wire for the diagonal.
And a diameter of the stand. What would you like to choose? Diameter for the.
Upendra,
Flash
while you're
off,
working on the diagonal, can we move on to the other lab? Because we are interested in seeing what
Sure,
Ashok
sure.
has done.
Okay. Switch to the other lab.
And then
Yeah.
we'll ask John or Miss
Yes.
Ton
Let's show them.
to
Let's
be
show them.
prepared for to deliver his talk. You can come with us, John.
Upendra, can you show us the
Yeah.
Yes,
final
yes.
results, or you are
Now
still
what we
working
did
on
is
it?
that we're now working on the diagonal. Now what we did,
2.7.
after the dilatation at a high pressure, both in the distal region and the proximal region, we put in an Evermine stent, which is a 50 micron stent. In the distally, we put in a 2.5 into 17 millimeter stent, and proximally we put in a 2.75 23 millimeter stent. And can you show the picture?
Yeah.
We'll show you the picture
Last
now.
shot.
इसमें से दिखा दो. We'll show you the picture. This is
Can we see the injection, please?
so. This is the result.
While you're
yes.
working on the diagonal,
you see
we
it now?
the? Yeah. Yeah, looks good.
Yes.
Now, we're going to post the late.
So now we're going to go to the diagonal.
So just your plan is to
We'll
fenestrate
recross it.
and that's it.
Yes.
Okay, so Upendra,
That's
because we have to leave you to to have the final talk of John Miston and then to close this session.
Great.
Thank you again for your great demonstration.
Okay, great.
It was very nice to see what you did on this particular really critical, difficult, calcified long lesion on this LED involving the bifurcation of the diagonal. So thank you very much.
Thank you,
John.
Chairman,
Thank you very much and see you soon.
ladies and gentlemen,